Stop recording now. And this is the third lecture. If you remember, the first two lectures, they were about the diagnosis, and most of the method that is used in diagnosis will be repeated here. So, starting with the normal pulp, we will talk about the pulp, then the periodontal area diseases, and the periapical area diseases. For the normal pulp, it is the symptom-free pulp, where the tooth is normal. It is responsive pulp to pulp testing. They normally does not exhibit any spontaneous symptoms. The symptoms produced from a pulp test are mild. They don't cause patient distress, okay? Results in a transient sensation, and this sensation resolves within seconds. What I meant by the pulp tests, meaning hot, cold application, pulp test application, the pulp tester, with a normal pulp, they respond with a normal limit. Once you remove the stimuli, everything turns to normal. Radiographically, for a normal tooth, you can see that there are varying degree of pulpal calcification, but no evidence for resorption or caries or any mechanical pulpal exposure. No endodontic treatment is indicated for such a tooth. No lamina dura widening, no internal resorption, just a normal pulp, no caries. We have pulpitis, but pulpitis have different types. Clinically, we deal with what we call it a reversible pulpitis that can be treated and the pulp return to normal, or the irreversible pulpitis. When I talk histologically about pulpitis, I need to define, is it acute, chronic, hyperplastic? Depends on the inflammatory response. For the reversible pulpitis, mostly it is caused by an exposure for the dentinal tubules. Okay. Such an exposure might cause dehydration, and that dehydration causes pain. So by definition, reversible pulpitis is a clinical condition associated with subjective, what the person feels of, and objective findings. It is what you will find, indicating presence of mild inflammation of the pulp. So this mild inflammation of the pulp can be progressed if it is neglected to irreversible pulpitis, while if it is treated, can go back to its normal situation. Causative factors, there are many, starting from caries to exposed dentin to attrition, defective restoration, incipient caries, and this is the attrition, some cervical erosion, and so on. Treatment, a fracture of a tooth can do that. So the pain is due to dentinal tubule. Okay, and isolate the exposed dentin or the vipal pulp. All of these will result in a symptom. No inflammatory will will be there. For the irreversible pulpitis, if the disease of the pulp remains, it will show some progression. So the inflammatory condition of the pulp can change to be irreversible pulpitis. At this stage, treatment is the removal of the diseased pulp. And such a condition could be symptomatic or asymptomatic. For a symptomatic irreversible pulpitis, this is a clinical diagnosis. Again, it is based on subjective, what the patient is telling you, and the objective finding that you are finding it during your diagnosis. You have your own diagnosis tool. So the vital inflamed pulp is incapable of healing in case of irreversible pulpitis. So if it is symptomatic irreversible pulpitis, there will be intermittent and spontaneous pain. So a rapid exposure for irreversible pulpitis for a dramatic temperature change could be a cold stimuli will alleviate and cause a prolonged pain to the patient even after removal of the. You can see here for irreversible pulpitis, the asymptomatic one, this one is symptomatic. Yes, here you can see the inflammatory cell, the polymorph nuclear leukocytes. Okay, and here you can see some fibrosis inside the pulp. Cell infiltration is clear. This is histologically. So the pain in these cases may be sharp or dull, localized or diffuse, or referred. So when the patient comes to you telling you that he is having a pain that prevent him from having a sleep, or maybe he will tell you that he have a localized pain, or sometime you will find it's a referred pain. So you should think about irreversible pulpitis. Typically, there are minimal or no change in the radiographic appearance of the periradicular bone because the inflammation is still there inside the pulp. It's not outside the tooth structure. Okay. But you might find a progressive caries, for example. This is a periradicular area. Normally, for such things, for irreversible, symptomatic, you might find caries. Okay. Some internal resorption, some bone resorption here, so that the cementum had been removed and the dentinal tubules are open and exposed. So with advanced irreversible pulpitis, thickening of the periodontal ligament may become apparent on radiograph, and there may be some evidence of pulpal irritation by virtue of extensive pulp chamber, you can see here, or root canal space calcification, or even internal resorption. See here, and this is the internal resorption. Deep restoration caries or pulp exposure or any other direct or indirect insult to the pulp. These will cause the irreversible. Sometimes patient comes to you with on X-ray is nothing, while the symptoms, they are irreversible pulpitis. ask the patient from the history, have he ever been on orthodontic treatment? Have he ever been on GA, under GA for operations, surgical operations? Because the person who's responsible for the general anesthesia or the endotracheal intubation process, they might push the tube inside the mouth with force, causing pulpitis, and that pulpitis, with the time, if it is neglected, it will cause irreversible pulpitis that might end up to necrosis. Then we will come to the asymptomatic irreversible pulpitis. Again, the clinical diagnosis is based on subjective and your objective findings, indicating that the vital inflamed pulp is incapable of healing. The patient does not complain from any symptoms. On occasion, deep caries will not produce any symptoms, which means that even if you have seen the patient with a very deep caries, he does not complain of any pain during eating or drinking. Radiograph even if you see on the x-ray that the caries is extended to the pulp, maybe it's left untreated. Maybe it was untreated and it turned to be asymptomatic. This is one stage before being necrotic, or maybe it is already necrotic. Okay. In case of asymptomatic irreversible pulpitis, endodontic is a must. Okay. For the irreversible pulpitis, here it is just a persisting of inflamed pulp, could be symptomatic and asymptomatic. In early stage, the pain for a sudden temperature change and continuous when the cause was removed. Okay, so this slide have for the important notes that persisting inflammation, which means acute inflammation, if it is neglected, it will reach to irreversible pulpitis. That reversible pulpitis could be symptomatic or asymptomatic. Either cases, you should treat it by the removal of the pulp. In early stage, when you want, before being necrotic, there will be symptoms, pain on sudden temperature change, and the pain will continue even after the removal of the stimuli. In later stage, when it is already necrotic, pain increases, before being necrotic, the pain increases with intensity, and sometime, with the applying of the stimuli, it will be, even if you remove the stimuli, the pain will be increasing, and sometime it will awake the patient at night. That is when a necrotic tends to be subacute. It is too late stage. So either you extract or you do a root canal. Remember, on radiograph you will not see any periapical. So the causes for the pulpitis are 3 and maybe more. All of them means there is some insult to the pulp. Tooth fracture, exposed pulp, extensive restoration, deep caries, or maybe exposed pulp or an exposed pulp during operation. All of these can cause pulpitis. But is that pulpitis have a clinical symptom or no? If it has a clinical symptoms, depending on some subjective findings or objective findings, the subjective, when the patient tells you that he is sensitive to a thermal change during eating and the persistence of the response to hot and cold, severe lancetating or throbbing pain if the intrapulpal abscess is there. The objective findings that increase in the sensitivity to the pulp tests that we do, it is not tender to percussion unless if the inflammation is spread to the periapical region. If I have no clinical symptoms, mild intermittent pain that goes and comes, or response to thermal stimuli, reduced response to the valve vitality test, so this is asymptomatic irreversible pulpitis. By the way, the response to the thermal stimuli, it is there because there is a dilatation of the gases and the fluid inside the pulp, and those can cause the pain, not because there is some nerves are still vital in the pulp. Remember this. This is a comparison between reversible pulpitis and the irreversible pulpitis. Okay? The type of the pain, how it is stimulated, what is your response or the patient's response to it. If that was not treated, so it will end up to pulp necrosis, which means the death of the pulp. When a pulp necrosis happens, means that there is no blood supply and the nerve endings are not functional. And it will stay like that, not symptomatic, till there is a spread of the infection to the periradicular tissue. Then the patient will visit his dentist. Normally, such a tooth does not respond to any electrical pulp test or cold stimuli, but they respond to heat. When we put the hot application, the tooth will respond after definitely a delayed time due to the fluid and the gases in the pulp canals space are expanding, and after expanding they extend to the periapical area from where the pain will be elicited. Pulp necrosis, sometimes it's partial, sometimes it's complete. Especially in the multi-rooted teeth, we expect that one tooth is necrotic, maybe the other is not. So a pulp necrosis in the absence of restoration or caries present on a clinical examination, as a history there was no luxated injury, maybe the cause is due to some longitudinal fracture extended from the occlusal surface to the pulp. To diagnose such a case, it's better to take bite wing x-ray and ask the patient to bite on something showing the fracture. Other cases, more advanced cases of inflammation, is what we call it normally a pulp polyp, is a chronic hyperplastic pulpitis. It's an overgrowth of the pulp tissue outside the boundary of the pulp chamber. Mostly it is seen in the deciduous teeth and maybe in the first molar of a permanent molar. This is asymptomatic irreversible pulpitis. Maybe he bleeds, but he does not feel pain from the tooth. So it's just the granulation tissue that's extend outside the pulp chamber. Problems of the pulp could be due to a previously treated tooth, but it was treated wrongly. For example, short root canal treatment, short under, we call it under. The filling is under, so it will leave some necrotic pulp tissue, and that causes pain because it will be later, sooner or later, it will be extended to the periapical area, and that really causes a periapical inflammation. This leaves some necrotic pulp here and here that was treated later on. This is an overextended treatment, and they did a perforation to the root canal. There is a zip here. There is no foramen. Okay. Then after the treatment, everything will subside. Okay. In radiographic, you can see some spacing. Okay. In the some lamina dura or some periapical changes, as in here, some radiolapical area. Previously treated tooth with pulpotomy, for example, or pulpectomy, which is partial endodontic treatment. Such a partial endodontic treatment is performed for emergency procedure, okay, not a permanent treatment. So for an irreversible symptomatic or asymptomatic, such a treatment, okay, some epixification, epixogenesis therapy, traumatic tooth injury. Okay. If you face, or if a patient came to you with the tooth with such a pain, and the tooth was treated previously with incomplete removal of the pulp tissue, whenever, if you decide to retreat the tooth with root canal, remember, application of such materials might change the position of the orifices. Sometimes you might end with calcified canal because of such a treatment. You should be aware of this treatment of the arterioles, or a creation that occupy almost the entire pulp chamber. It is really variable. They don't have a classification. The cause of the pulpal classification is unknown. It may be occur around a nidus of degenerating cell, blood thrombi, accumulation of collagen fiber. Maybe, by the way, collagen fiber increases inside the pulp if there is inflammation. So maybe a neglected inflammation can cause that. Luxation of the teeth as a result of a trauma. Also, they may cause calcific metamorphosis, a condition that can, in a matter of months or years, lead to partial or complete obliteration of the pulp due to deposition of mineral tissue, similar to the cementum, okay, or occasionally bone on the dentin wall. Also, we call them internal ankylosis. All of these can be caused, but there is no Clinically, on the patient mouth, they look yellowish if you compare it with the adjacent teeth. So any prophylactic treatment is worth it, really. Sometimes the stones are diffused everywhere, like this. Sometimes they are concentrated, you see here. Sometimes they are like that. They block the canal. It is not a pathological process related to injury or natural phenomena. It's not clear. But they really handle it. You cannot do a root canal treatment. Sometimes you will deal with cases of internal resorption, like here. It's appear in the X-ray. And the tooth will look pink in color. There's a pink spot. But listen here, this on radiograph looks like, really it looks like an internal resorption. While clinically you can see maybe it's a class 5 here. If it's treated, everything will be fine. But if you are going to deal with a tooth with an internal resorption, take care, because there might be perforation on the mesial side or distal side. These are due to the presence of the inflamed tissue for a long time, so it needs treatment. For old patients, remember, always the pulp chamber is smaller than its normal size. Okay, even the root canals, there will be gradual decrease in the cellularity and concomitant increase in the number and the thickness of the collagen fiber. Okay, look here how thick is the pretubular dentin and how narrow will be the tubules. The odontoblast will decrease in size and number, and they maybe disappear altogether in certain areas of the pulp, particularly on the pulpal floor, over the bifurcation and the trifurcation area of the multi-rooted teeth. With age, there is a progressive reduction in the number of nerves and the blood vessels. So, and the main change, as I mentioned before, with aging is increase in the peritubular dentin. Dentinal sclerosis, number of dead tracts will be increased or expected to be there. Dentinal sclerosis will gradually cause decrease in the dentin permeability, and as the dentinal tubule reduce in diameter.